research she has done already in this topic. So I would like you to take as much as possible from her slides and Dr. Ahmed and mine. It will be very beneficial. So if you have any questions, we'll leave them at the end. Or if you have very urgent questions, you can ask the speaker by the end of the lecture. In the meantime, I would like to welcome our Assistant Director for joining us here. And we'll start, inshallah, immediately.
Role. Volunteers are packing meals with care. Families are waiting with hope. Children are
Professor for coming and appreciating your attendance here with us today.
Dr. Ahmed Ibri,
Mr. Salih, thank you for organizing this lovely workshop.
So, at the beginning, we will start with Dr. Ahmed's lecture. It is an introduction and a pass-through for the rest of the workshop. It is very informative and it will give you a start and guidance for the beginning of the program. So I would like you just to listen carefully, and if you have any questions,
Bismillahirrahmanirrahim. Assalamu alaikum. My name is Ahmed Ibri. I'm a biologist in the ENT department. I'm going to speak briefly about balanced engagement and the differences between central and peripheral, which is ENT causes of the balance. We'll go through a major scale of how to identify first the cause of the balance and then how to treat it. I will leave the treatment details for our delegates, but I'm mostly concerned about how to differentiate between what is ENT and what is not ENT in general. So I know from your registration paper that you came from different specialties, physiotherapists, I believe, staff nurses, doctors, maybe GPs. So the basics are there. I'm just refreshing you with the basics of ENT and balance. So in general, we have the vestibular system. Our concern in ENT, the reason why we are maintaining balance, but actually not the ENT, it's integration of different parts. These parts coming through the eyes, the proprioception, the cerebrum, all integration. This is all input gathered and explained to the brain. Then the brain nuclei give the output order, and the output order is by maintaining normal gaze and posture. So any disruption of any of these inputs can lead to imbalance. So we are investigating actually the input, which part of the input have the issue, so we can treat them. In ENT, we are concerned about the vestibular system, the semicircular canal, which we have three of them: posterior, anterior, and horizontal. So it's not just a one organ job; it's actually multi-organ system. So in general, I like to differentiate between what is vertigo and what is non-vertigo. So this is a good classification of both terms. We have the term vertigo, which is the objective vertigo, which means usually the spinning surrounding. So the patient comes to you with the feeling that the surrounding is spinning. In this case, we call it vertigo. Whatever description given by the patient which does not fit this criteria, we call it non-true vertigo. We call it subjective. And there's a lot of terms used by the patient or by the medical staff, like dizziness, which is the woozy or ambulance, and steadiness, which means that patient will feel that I'm deviating to one side or I'm not maintaining the posture, and lightheadedness, which is almost like a presycopic attack. So whatever terms usually the patient use, which is not the spinning surrounding, we call it non-true. Only the spinning surrounding, we call it the true vertigo. It is important to investigate this term with the patient, because patient usually will come and have the term of vertigo, but you have to explain it. Have you go through the term itself and identify what the patient means by the vertigo. So in evaluation of any patient, we usually should depends on history. 70% of your diagnosis and treatment should be based in history. Physical examination is important in this part, but the physical examination is to prove your diagnosis. You have to establish it first, then you have to prove it or rule it out. Lab test in our specialty ENT has really no, but it's major role in central process. So we have to investigate that process. But anyway, in case in central or peripheral, you have to be careful with your history. Detailed history is okay to establish a diagnosis. Let's talk first of all about the ENT process. So in general, 20% of the population will have dizziness in their life. But out of them, 34% of them will have ENT related causes. So in general, what we are saying that only 1/3 of balance problem is coming from here. So majority of the cases are not here, actually. Other causes, these other causes, we call it central. So we have only 4 causes of the referral balance issues in ENT. Either we have benign paroxysmal positional vertigo. I'm going to explain each one of these conditions separately. We have Meniere's disease. We have vestibular neuritis plus minus labyrinthitis. And we have the third wind syndrome, which including fistula and something called semicircular canal disease. These are the causes of balance issues in ENT. The most common cause is benign paroxysmal positional vertigo. It's simply there's a calcium debris moving in the semicircular canals. While moving, the patient feels dizzy. Usually associated with nausea or vomiting, or both or neither of them. But patient main complaint is imbalance while I'm moving my head, usually in sitting or sleeping in supine position. Most of the cases I saw, patient comes with the feeling that at night I'm trying to put my head on the pillow, I feel the surrounding is dizzy, nauseating, sometimes I'm vomiting, sometimes I'm not. The causes of it is actually 50% is idiopathic. So there's